Hello everyone, this is Dr. Meenakshi Gupta. Today I am going to start another topic of pharmacology from the central nervous system, that is psychopharmacology or psychopharmacological agent. So what is the psychopharmacology? Cytopharmacology, it is a science which deals with the state of mind. And psychopharmacological agent, these are the agent, or we can say also psychotropic drug. Psych is mental processes, so they are going to control the psych or mental processes of the person. And this group of the drug, this is mainly used for various psychiatric disorder. यहाँ पे use होती है. Now how we can categorize before starting with the psychopharmacological agent, you must know the various type of psychiatric disorder where we can use this group of the drug. So it is categorization of the psychiatric disorder. It is not that very much clear, but depending upon the predominant manifestation, we categorize it into three. So one is psychosis, neurosis, and affective disorder. So psychosis, what is a psychosis? It is a severe psychiatric illness. It is a severe psychiatric illness. So there is a severe distortion of the thought and behavior of the person, and the insight of the illness, the important is insight of the illness, that is absent. Patient does not know that is he is suffering with the illness. This is making it severe. So insight of the illness, that is absent. And another important sign and symptom which you will be seeing in most of the psychotic patient, they are delusion and hallucination. They are present. Now what is delusion and what is a hallucination? So delusion, it is a false but firm belief in something which is not true. It is a false and firm belief in something which is not true. Even if you are going to provide the evidence, then also person is not going to believe. So there are various type of delusion, like if delusion, paranoid delusion, okay? Like we have a, suppose a paranoid delusion. Here what the person is having that firm belief that somebody wants to damage him, somebody wants to kill. So even if you are going to provide the evidence that nobody is after you, but still the person will not believe. Then and then other type of delusion, you can see delusion of grandeur. So here the person will be seeing himself big, like the best example is like cat if looking in the mirror seeing herself as a lion. So this is a delusion of grandeur. Now coming to the hallucination. So what is a delusion? It is a false belief in something which is not true. Now what is a hallucination? Hallucination, it is a false perception. So it can be auditory, it can be visual. So here in psychosis we see this auditory hallucination. Means person is perceiving, false perception is person is going to perceive as if somebody is talking. Person is auditory, hallucination is person will be hearing the voices, and that voices maybe it is coming from the sky, from somewhere, from the third person, and it can be like full commentary type, and it can be like the person is hearing the voices, do this, do that, as if God is saying something, somebody is calling from the sky, or maybe hearing two voices, they are talking together about himself or herself. So this all is going to derange the behavior, and the thought process of the person will be affected because of that. So visual hallucination, that means person is seeing something, though there is nothing, but there will be false perception. The person will be seeing the people, and people, they are dancing in front of him or her. So that is a visual hallucination. So here in the psychosis, patient will be having auditory hallucination and paranoid delusion. So another terminology which we use, though it is not related with here, that is illusion. What is the illusion? Illusion is a false interpretation. Like the person is uh, interpreting the rope as a snake. So that is a illusion. So in the psychosis, delusion and hallucination, they are there. Now neurosis, the coming to the second psychiatric disorder, that is a neurosis. It is a less severe in comparison to the psychosis. So less severe psychiatric illness. Here what happens, the insight of the illness, that is there. So insight of the illness is present. So this is going to make it less severe, and there is no delusion. There is no delusion and no hallucination. So these are absent. Now in the affective disorder, what happens in the affective disorder? The mood of the person, that is altered. This is related with the mood. So it is not related with the thought, it is not related with the behavior. So mood of the person is altered, and there is a change in the state of the mood. So these are the three type of mental disorder. We have psychosis, we have neurosis, and we have a affective disorder. Now psychosis. For the psychosis, it is of two type, organic and a functional. In a organic psychosis, you will be finding some cause. Cause will be there. It can be some pathological cause, it can be some toxic cause. So cause will be there, it can be pathological or anything. Whereas in a functional psychosis, there is a no well defined cause, that is there. No well defined cause is there in functional psychosis. So organic psychosis, what cause can be there? There can be infection like rabies, injury due to heavy metal poisoning like mercury and lead, chronic alcoholism, then cognitive disorder. So here in the organic psychosis, there will be dementia, there will be disorientation and disorganized thought and behavior. And this dementia and disorientation, this is not seen in functional psychosis, but definitely the thought and behavior will be altered even in a functional psychosis. So in a functional psychosis, what all we have? We have a schizophrenia, and another one is we have a paranoid state. So very shortly I will be telling about the sign and symptom of the schizophrenia. So basic difference in the organic psychosis and the functional psychosis is, in one, the well defined cause is there, whereas in functional psychosis no cause is there. And another one is dementia and disorientation, that is there in the organic psychosis, whereas the disorientation and dementia, that is not seen in the functional psychosis. Now coming to the another mental disorder, that is a another psychiatric disorder or mental disorder, that is a neurosis. So neurosis, it is a less severe psychiatric illness. The insight of the illness, that will be there. So patient को पता होता है कि उसे ये problem है, and no delusion and no hallucination, that is seen in the neurosis. So under the neurosis we have a anxiety. So what is the anxiety? It is the unpleasant state of the mind where the patient is worried about the patient shows a concern, worry about the future. Okay? So unpleasant state, that is the anxiety. Phobic states, fear of some unknown object, fear of some unknown situation or some person. So different person, they have a different phobia. Like few people, they have a phobia of the closed spaces, like claustrophobia, height ka phobia hota. So different people, they have a different phobic state, and they know they have that phobia. Next is obsessive compulsive disorder. Here what will happen, patient is doing some ritual and person knows, but he is not able to get rid of that thing. So there is some obsession is there, which is going to lead to the compulsion. So what is obsession? Suppose the person is having this obsession every time the person is thinking his or her hands, they are dirty. So what will the person will be doing? The person will be washing hands, his or her hands many times in a day. So that is a obsessive compulsive disorder. Then another one is reactive depression or a neurotic depression. So what is a reactive depression? So here one is endogenous depression, where something is wrong with the neurotransmitter in the brain. Reactive depression, here cause is there. It is due to some cause, maybe loss of near and dear, loss in the examination, loss of the job. So something is there, that cause is there, that is in reaction to that the person is suffering with the depression. And here if you do the counseling, we can treat it without giving the antidepressant drug to the person. Then another is post traumatic stress disorder. Here what happens, some trauma is there. Trauma, it can be in the form of war, it can be in the form of riots, it can be in the form of earthquake, and patient may be losing something, that is going to lead to post traumatic stress disorder. So these are the various type of neurotic disorders. So we have anxiety, phobic state, obsessive compulsive disorder, reactive depression, and post traumatic stress disorder. Now the third one is affective disorder. So under the affective disorder, the mood of the person that is altered. This is related with the mood, not related with the thought process patient का कुछ नहीं होता, behavior is also not. So here it is mainly of two, mania and depression. So in the mania there is a elation of the mind, okay, hyperactivity of the mind, sleep will be reduced, and the person will be very agitated, and behavior will be maybe, so person will be agitated and maybe violent. On the other hand, depression is just opposite of the mania. So person will be sad, full of guilt, and person will be thinking he is not worth. So all that, they are the symptom of the depression. So this manic depressive psychosis, so this mania and depression, they can be a part of psychosis. Like manic person, there may be a loss of insight. Suppose the person is going by airlines and thinking that he is going to give aeroplanes to each and everybody, okay? So that is a so psychosis, it can be accompanied with the one side, patient may have a mania and patient may be having depression. So that is manic depressive psychosis. So all the things, they are together. So I have explained the three type of mental disorder: psychosis, neurosis, and affective disorder. So these are the three. Under the psychosis, the important is schizophrenia. Under the neurosis, we read the anti-anxiety drug, and under the affective disorder, we have mania, depression, and manic depressive psychosis. Now coming to the schizophrenia. Now what is a schizophrenia? It is a psychosis, but it is more than that of the psychosis. So what happens in a schizophrenia? It is one of the important form of psychiatric illness, and it mainly affects the young people. This is very important, and it is a chronic and highly disabling. So there are the two type of symptoms they are there. One is a positive symptom and another one is a negative symptom. So if we say the positive symptoms, positive is something is added to in that person which we do not see in the normal person. So some addition that is there. So positive symptom is the most important is delusion and hallucination. So already I have explained. So what kind of the delusion will be there? It is a paranoid type of delusion. So it is a also split personality. So splitting between the thought and between the reality. So that is going to lead that there is no coherence. That leads to the split personality. And positive symptoms, it is there will be hallucination. What type of hallucination will be there? It is a auditory hallucination. Delusion, paranoid delusion will be there. And person's thought, that is totally thought and behavior, they are also altered in schizophrenia. So abnormal behavior will be there. Then what is the negative symptom? Negative symptoms is which we do not see in the something which we see in the normal person, but that is missing in the schizophrenic person. Like person will be totally in his or her own world. So totally introvert behavior will be there, and person will be social withdrawal. I already told a person will be totally in his or her own world. And what will be the, like, there is a range of emotions in a normal person. The person may be sad, person may be happy. If we say ki in your family somebody has died, and this patient, they do not feel any kind of emotions. So flattening of the emotional responses, flattening of the emotional responses means it is not like that ki patient is like in depression, patient is feeling sad. Okay, so here it is not only the patient is not going to feel the sad, as well as the patient is not going to feel that happy moment. So that pleasure part, that is also missing, and there is a lack of motivation. So that what is the goal in their life, that is totally missing in that person. And then speech, that fluent speech, that is lost. And there is a cognitive deficit, that is a lack of attention and lack of memory, that is also seen in few of the patient. So these are the positive and negative symptom of the schizophrenia. So positive symptom, the most important is delusion, hallucination, thought and behavior. And negative symptom, social withdrawal, introvert behavior, flattening of the emotional responses, lack of motivation, poverty of the speech and cognitive deficit. So here what happens, it is chronic and usually highly disabling, and insight of the illness, that is not there. Here what happens, like if even the, how we can tell about the schizophrenic patient. So one side the person is sitting, schizophrenic person is sitting, and on the other side the psychiatrist is sitting, and they are not able to, that schizophrenic person is not able to understand, as if both they can see each other, they can see each other, but they are not going to understand, as if we can see a thick glass wall that is present in between these two. So this is how we explain the schizophrenic person. What is the important pathogenesis? Though as such how this disease it started, so that is still not clear. There are the few hypotheses, on the basis of that we can explain what is the pathophysiology of the schizophrenic, and we give the uh, and as such there is no drug which can cure this disease. It is only going to give the symptomatic treatment. But if we come to the pathogenesis, so inheritance that play an important role. They say it runs in a family. If the person suffers and it runs in a family, so next generation chances are 10% the person may be affected. Okay, then another one is abnormality in the neurotransmitter function. So what are the neurotransmitter which are affected in schizophrenia? We have the three: dopamine, 5-HT and glutamate. So what they say, there is increased in the dopaminergic activity. So where the dopaminergic activity that is increased, so for that you must know the dopaminergic pathway. So in the brain, the area which is rich in dopaminergic neurons, that is this ventral tegmental area. This portion, it is rich in dopaminergic tegmental, the area which is rich in a dopaminergic neuron, so the cell body. And this is a part of midbrain situated next to this substantia nigra. You can see this blue color. Now the dopaminergic nucleus, they are here. From here the dopaminergic fibers, they are going to project to nucleus accumbens, Na. This is a part of limbic system. So you can see here with this line, from here it is. So positive sign, so I'll make it a little bit thicker. So positive, this pathway is because this is a midbrain. This is a part of limbic system, nucleus accumbens. This is a part of limbic system. This is a part of midbrain. So this pathway we say it is a mesocortical pathway. Sorry, mesolimbic pathway. So there is increased dopaminergic activity in this pathway, which is mainly responsible for the positive sign and symptom. Then from the ventral tegmental area, the dopaminergic fibers, they project to the frontal cortex. And here what it is, I'll just make a dotted line. So dotted line indicates there is a decreased, and this pathway is called, again it projects from the ventral tegmental area to the cortex. So it is a mesocortical pathway. And there is a decreased in dopaminergic activity in this pathway, and which is responsible for the negative sign and symptom. So mesocortical and mesolimbic pathway, the increased dopaminergic activity, that is going to responsible for the positive sign and symptom like delusion, hallucination, thought and behavior disorder, whereas a negative sign, that is introvert behavior, social withdrawal, flattening of the emotional responses, that is because of the decreased dopaminergic activity in the mesocortical pathway. What are the other pathway which are their dopaminergic pathway? So from the ventral tegmental, the another one is the fibers from this substantia nigra, that this is another part which is rich in dopaminergic neuron. So from here the fiber, they project to the striatum. So striatum, we can see the part of the, it is a caudate nucleus and putamen. This is the pathway which is mainly responsible for the voluntary movement. So this pathway, it is from the substantia nigra to the striatum. इसको हम बोलते हैं नाइग्रो striatal pathway. Then another pathway is from ventral tegmental. This is the hypothalamus, this pathway. This is a tuberoinfundibular pathway. So these are the four pathway. Now what is the significance of this third and fourth pathway? So first pathway I have told mesolimbic, because of the increased dopaminergic activity there is the positive sign, whereas with the mesocortical there is decreased dopaminergic activity, that is going to cause a negative sign and symptom. And now what is the significance of this nigrostriatal pathway or the tuberoinfundibular pathway? Now the antipsychotic drug, they act, if we are going to give the antipsychotic drug, they are mainly going to block this activity. So they are dopamine antagonist. So what happen if they are going to block this dopamine? So they are not very much selective, they are going to block this also. So they are going to worsen the negative sign and symptom. They are going to block this also, nigrostriatal pathway. So person will be suffering with the extrapyramidal symptoms, and then they are going to inhibit this also. Then patient will be having endocrinological disorder. Mainly it is a increased prolactin level. So these are the important of other pathway. Though the antipsychotic drug, they act by blocking the dopamine where at the mesolimbic pathway, but they are going to block it at other site also. So this all is, now this dopaminergic pathway, here all these, they are going to act through what kind of receptor? It is a with the, there are total 5 type of receptor. They are there: D1, D2, D3, D4 and D5. But the antipsychotic drug related with that, it is a D1 and D2 receptor. The action is through this, and mainly this is relevant clinically, D2 receptor. So antipsychotic drugs, especially the first generation antipsychotic drug, they act by blocking this D2 receptor antagonist, right? Now this. Now, how we come to know there is abnormality in the neurotransmitter function or dopamine, there is increased activity of dopamine in the mesolimbic pathway. So, it is with the dopamine hypothesis that is there, which is going to strengthen this. Schizophrenia, it is because of the increased dopaminergic activity in the mesolimbic pathway. And how did they find this? They have found, number one, there is increased dopamine receptor density they have found in the schizophrenic patient with the PET scan. Number two, even in the postmortem of schizophrenic patient, this dopamine receptor density, that is more. Number three, if we are going to give something which is going to increase the level of dopamine, like dopamine आपने precursor दे दिया levodopa, and which causes the release of dopamine like apomorphine. Okay? They are going to increase the psychotic symptom. This is the number three evidence. Number four, majority of the antipsychotic drug, they act by blocking the D2 receptor antagonist. Number three, in the person with the schizophrenia, there is increased level of homovanillic acid. This is a metabolite of the dopamine which is found in the urine and CSF and the plasma. These level, they are more. So they are the metabolite of the dopamine, their level that is increased. So all these points, they say there is a increased dopamine activity in the mesolimbic pathway. But what happens? That means if we are going to give D2 receptor antagonist, we can cure the patient. But what happens? And in few patients, it is not effective. This D2 receptor antagonist, they are not effective. That means some other cause is also there. Then another thing is the few antipsychotic drugs, they are effective in the treatment of the psychosis, but they do not act by blocking the D2 receptor. That means some other receptor, they are also involved in the pathogenesis of the psychosis or in the pathogenesis of schizophrenia. So what are the other? That is a 5-HT. So second one number is, it is a 5-HT hypothesis. What does it say, 5-HT hypothesis? And how they have proved this? If we give 5-HT antagonist, okay? If we give a 5-HT antagonist like LSD to a person, lysergic acid diethylamide, अगर हमने ये दिया, which is a 5-HT antagonist, what happens? They are going to produce the psychotic symptoms. If we are going to give the 5-HT agonistic drug, okay, that means there is increase in the level of 5-HT also. So serotonin, that is also involved. So there are few atypical so this is the number one. So with the 5-HT agonist LSD, they are going to produce the psychotic symptom. Number two, the atypical antipsychotic drug, they act by blocking this 5-HT2 receptor. They are effective as an antipsychotic. psychotic. The only difference with the LSD, the psychotic symptom, the hallucination, that is a auditory. It is not the, sorry, it is a visual hallucination that is seen with this, not the auditory hallucination. So this is the number 2 hypothesis. So one is a dopamine and another one is a 5-HT hypothesis. So atypical antipsychotic, they act by blocking the 5-HT2 receptor. Now coming to the number 3, glutamate. Now what they have found, what the glutamate hypothesis is, they say. So they glutamate hypothesis is, if we give glutamate antagonist, NMDA receptor antagonist, if we have given like ketamine, ये अगर हमने दिया पेशेंट को, phencyclidine, so they are going to produce the psychotic symptoms. This glutamate, so ketamine, phencyclidine. So what we can give, so these are the NMDA receptor antagonist. Now here important is this glutamate and dopamine. Increased glutamate and decreased dopamine. First I will say not increased. Decreased glutamate and increased dopamine, they are going to affect this GABAergic activity. Okay, now what they are going to do to this GABAergic activity? So they are going to decrease the GABAergic activity. So decrease glutamate and increase dopamine, they are going to decrease the GABAergic activity. Now this GABAergic, they have inhibitory control. Now what happens if we do the opposite? If we increase this glutamate and decrease, on the contrary, if we increase glutamate and decrease, then what they are going to do? They are going to increase GABAergic activity and there will be inhibitory control will be there, which we want. Okay, so that's why we can give this for the treatment. We can give glutamate agonist and dopamine antagonist. As such, we do not have any drug which can increase the glutamate for the treatment of the psychosis, but definitely we have the drug which is going to decrease the level of dopamine. So these are the various hypotheses related with the pathogenesis of the schizophrenia. Now, how we can treat it? What are the treatment part of this? So we can give the psychotropic agent. So we have a already I have told psychopharmacological agent or psychotropic agent, the drugs which we are going to use for the treatment of mental processes. So under that we have psychotherapeutic and psychomimetic, psychotomimetic, psychotherapeutic which are going to treat, and psychotomimetic which is going to produce a psychosis like LSD type of drug. So under the psychotherapeutic, ये वाला, this is portion psychomimetic which is going to produce the psychosis. Under the psychotherapeutic agent, we have antipsychotic, we have antidepressant, we have anti-manic, and we have a anti-anxiety. So one terminology, this tranquilizer, this is an older terminology for the antipsychotic drug. So what is a tranquilizer? It is the agent which is going to produce the calmness to the mind. produces the calmness. And that time we had only one drug, that is a chlorpromazine. We used to say it is a tranquilizer. So used to label it major tranquilizer, and for the anti-anxiety used to use minor tranquilizer. But they say anti-anxiety drug, they are more commonly used as compared to the antipsychotic drug. So this terminology with the major and minor, they are obsolete. They are not used because major, that is not very commonly used as compared to the minor tranquilizer. So ye wali abhi terminology we are not using this one. But you must know what is a tranquilizer. They are the drug which are going to produce a calmness. Okay. Then for the antipsychotic, this is number one. The other terminology, that is a neuroleptic drug. This is a first generation antipsychotic drug. What the first generation antipsychotic drug they used to do, they are mainly act by blocking the D2 receptor. But they are not only going to block the D2 receptor only in the mesolimbic pathway where there is an increased dopaminergic activity. Apart from that, they are going to block the dopamine receptor in rest of the pathway, and especially in the nigrostriatal pathway. So once they are going to block this pathway, then what will happen? The person will end up with the extrapyramidal symptoms. So neuroleptic, they are the drug antipsychotic which is going to produce the extrapyramidal symptoms. So this is seen with the first generation antipsychotic. Then came the second generation antipsychotic or atypical antipsychotic. With that, we do not see the except one or two, we do not see the extrapyramidal symptoms. So now presently, for both first generation and the second generation antipsychotic, we are going to use this terminology antipsychotic drug. So in the next video, I will be discussing about the antipsychotic drug. So if you have any query, you can ask in the comment box. If you like my video, please share it and subscribe my channel. So that's all about today's video.